pediatric disorders involving the blood, the organs responsible for producing blood cells, and the lymphatic system. These disorders range from very common conditions, such as iron deficiency anemia, to life-threatening illnesses, including leukemia, and inherited disorders such as sickle cell disease and hemophilia. Regardless of the diagnosis, these conditions can significantly affect a child's ability to transport oxygen, fight infection, or control bleeding. As nurses, it's important to remember that children are not simply small adults. Their blood volume is much smaller, their bone marrow functions differently throughout development, and they often compensate remarkably well before suddenly becoming critically ill. Because of this, early recognition of subtle assessment findings is essential. Throughout this lecture, think about the normal functions of blood. Blood transports oxygen, carries nutrients, removes waste products, fights infection, regulates body temperature, and helps maintain fluid balance and clotting. When any component of the blood is affected, multiple body systems can be impacted. We'll also discuss the lymphatic system because it plays an important role in immunity. Enlarged lymph nodes, recurrent infections, or abnormalities in white blood cells may all be clues that a child has an underlying hematologic or lymphatic disorder. As practical nurses, your responsibilities include performing thorough assessments, recognizing early signs of complications, administering medications and blood products safely within your scope of practice, providing family education, monitoring for adverse reactions, and communicating changes in the child's condition promptly to the registered nurse or healthcare provider. As we move through each disorder, don't focus on memorizing isolated facts. Instead, ask yourself 3 questions. What is happening in the body? How will the child present? What nursing interventions will keep this child safe? If you can answer those 3 questions, you'll be well prepared for both the NCLEX and clinical practice. Before discussing specific blood disorders, let's review the lymphatic system, which plays a vital role in immunity and fluid balance. The lymphatic vessels collect excess fluid from the tissues and return it to the bloodstream. As lymph passes through the lymph nodes, bacteria, viruses, and other foreign substances are filtered and destroyed, while lymphocytes help stimulate antibody production. Children commonly develop lymphadenopathy, or enlarged lymph nodes, during infections. This is often a normal sign that the immune system is responding appropriately. However, enlarged nodes that are persistent, painless, hard, or generalized may indicate a more serious condition, such as leukemia or lymphoma. The spleen is the largest organ of the lymphatic system. It filters blood, removes old red blood cells, stores platelets, and helps fight infection by bringing blood into contact with lymphocytes. One of the most common abnormalities is splenomegaly, or enlargement of the spleen. This may occur with infections, hemolytic anemias such as sickle cell disease, liver disease, and some cancers. Because an enlarged spleen is more prone to rupture, children with splenomegaly should avoid contact sports and activities that could cause abdominal injury. As nurses, remember that enlarged lymph nodes or an enlarged spleen are assessment findings, not diagnoses. Your role is to recognize these changes, assess for associated symptoms, and promptly report concerning findings to the healthcare provider. Anemia is not a disease itself. It is a condition that results from many different underlying causes. Regardless of the cause, anemia occurs when there is too little hemoglobin or too few red blood cells, reducing the blood's ability to carry oxygen to the body's tissues. Because the tissues receive less oxygen, the body tries to compensate. The heart pumps faster and harder to deliver more oxygen, increasing cardiac output. When hemoglobin falls below about 8 g/dL, the body begins shunting blood away from less vital tissues, such as the skin, and toward vital organs like the heart and brain. If severe anemia is left untreated, this increased workload can eventually lead to heart failure, especially in young children. Children with anemia commonly present with pallor, fatigue or weakness, tachycardia, tachypnea, and shortness of breath. The severity of symptoms often depends on how quickly the anemia develops. A child with chronic anemia may appear relatively well despite a low hemoglobin level because the body has had time to adapt, whereas acute blood loss can produce severe symptoms much more rapidly. As nurses, our role is to recognize these signs early, monitor for worsening oxygenation, identify the underlying cause of the anemia, and implement appropriate interventions to restore adequate oxygen delivery. Iron deficiency anemia is the most common nutritional deficiency in children and the most common type of anemia you'll encounter in pediatric practice. It occurs when the body does not have enough iron to produce adequate amounts of hemoglobin, reducing the blood's ability to carry oxygen. The highest incidence occurs during periods of rapid growth, particularly between 9 and 24 months of age, and again during adolescence, when iron requirements increase significantly. Iron deficiency anemia has several possible causes. Children may lose blood through hemorrhage, have difficulty absorbing iron, require more iron because of rapid growth, or simply not consume enough iron-rich foods. One important pediatric teaching point is that whole cow's milk should not be introduced before 12 months of age. Cow's milk is low in iron and can irritate the intestinal lining of infants, causing small amounts of gastrointestinal bleeding over time, which contributes to iron deficiency. Excessive cow's milk intake after infancy can also reduce a child's appetite for iron-rich foods. As nurses, one of our most important roles is prevention through education. Teaching families about age-appropriate nutrition, limiting excessive milk intake, and encouraging iron-rich foods can significantly reduce the risk of iron deficiency anemia in children. Sickle cell disease is an inherited disorder that affects the structure of hemoglobin, causing red blood cells to become rigid and sickle-shaped under certain conditions. These abnormal cells do not move easily through blood vessels, leading to blockages, pain, and reduced oxygen delivery to tissues. It's important to distinguish between sickle cell trait and sickle cell disease. Individuals with sickle cell trait inherit the abnormal gene from only one parent. They have a mixture of normal hemoglobin HbA and sickle hemoglobin Hbs, usually have normal hemoglobin levels, and are typically asymptomatic. In contrast, children with sickle cell anemia, the most severe form of sickle cell disease, inherit the abnormal gene from both parents. Symptoms usually do not appear until about 6 months of age, when fetal hemoglobin declines and sickle hemoglobin becomes the predominant form. One of the earliest signs is dactylitis, or painful swelling of the hands and feet caused by blocked blood flow in the small vessels of the bones. As sickled red blood cells clump together, they obstruct blood vessels and reduce oxygen delivery, causing ischemia, severe pain, and potential damage to organs and tissues. As nurses, it's important to recognize that sickle cell disease is a chronic condition with acute complications. Throughout this chapter, we'll discuss how to recognize sickle cell crises, manage pain, prevent complications, and provide education that helps children and families maintain the best possible quality of life. Children with sickle cell disease can experience several types of acute crises, and it's important to recognize each one because they require prompt intervention. Although they have different causes, all are considered medical emergencies. The most common is the vaso-occlusive crisis, also called a painful crisis. Sickled red blood cells become trapped in small blood vessels, blocking blood flow and reducing oxygen to the tissues. This causes severe pain, swelling, and tissue ischemia. Nursing priorities include rapid pain management, hydration, oxygen if needed, and treating any underlying trigger, such as infection. The second type is splenic sequestration, which occurs when large amounts of blood suddenly become trapped in the spleen. The child may develop rapid splenic enlargement, severe anemia, tachycardia, hypotension, and signs of shock. This is a life-threatening emergency that often requires blood transfusions. And a aplastic crisis occurs when the bone marrow temporarily stops producing red blood cells, most commonly after a parvovirus B19 infection. Because children with sickle cell disease already have shortened red blood cell survival, they can quickly develop profound anemia. Watch for extreme fatigue, pallor, and a sudden drop in hemoglobin. Finally, a hyperhemolytic crisis involves an unusually rapid destruction of red blood cells, resulting in worsening anemia and jaundice. Although less common, it can also be life-threatening. As nurses, remember that regardless of the type of crisis, early recognition, careful assessment, pain control, hydration, and prompt communication with the healthcare team are essential to preventing serious complications. Thalassemia is a group of inherited blood disorders in which the body cannot produce enough normal adult hemoglobin. Without adequate hemoglobin, red blood cells are small, fragile, and destroyed prematurely, resulting in chronic hemolytic anemia. To compensate, the body increases production of fetal hemoglobin and works harder to make red blood cells. This increased demand causes the bone marrow to expand, which can lead to bone deformities and enlargement of the liver and spleen in severe cases. Thalassemia is classified according to which hemoglobin chain is affected. The most common form is beta thalassemia, in which production of the beta globin chains is impaired. There are two main forms. Thalassemia minor is usually mild, and many individuals have few or no symptoms. Thalassemia major, also known as Cooley anemia, is much more severe. Children often require lifelong blood transfusions, which can lead to iron overload and the need for iron chelation therapy. As nurses, it's important to recognize that children with thalassemia require ongoing monitoring for anemia, growth and developmental concerns, complications of chronic transfusions, and support for both the child and family as they manage this lifelong condition. Hemophilia is an inherited bleeding disorder in which the body lacks one of the clotting factors needed to form a stable blood clot. Because it is an X-linked recessive disorder, it primarily affects males, while females are most often carriers. In some families with a known history, prenatal testing can identify the disorder before birth. The two most common types are hemophilia A, caused by a deficiency of factor V8, and hemophilia B, also called Christmas disease, caused by a deficiency of factor IX. Regardless of the type, the result is the same. The blood cannot clot normally, so bleeding lasts much longer than expected. Unlike children with low platelet counts, children with hemophilia typically experience deep bleeding rather than tiny pinpoint bruises. They are especially prone to bleeding into joints, called hemarthrosis, as well as bleeding into muscles and soft tissues. Repeated joint bleeding can lead to chronic pain, decreased mobility, and permanent joint damage. As nurses, our priorities are to prevent injury, recognize signs of internal bleeding early, administer clotting factor replacement as prescribed, and teach families how to respond quickly to bleeding episodes. With early treatment and good preventive care, many children with hemophilia can live active, healthy lives. Children with hemophilia are at risk for prolonged and sometimes life-threatening bleeding because their blood cannot clot effectively. Bleeding may occur after even minor injuries, dental procedures, or surgery, and in severe cases, it can occur spontaneously. With significant bleeding, laboratory findings may include anemia from blood loss. If the child is actively hemorrhaging, they may also develop tachycardia, hypotension, pallor, and other signs of hypovolemic shock. Another common manifestation is spontaneous hematuria, or blood in the urine, which should always be reported and evaluated. Children may also experience bleeding into muscles or joints, leading to pain, swelling, and decreased mobility. The most serious complication is bleeding into the brain or neck, which is a medical emergency. Nurses should recognize warning signs such as a severe headache, vomiting, changes in mental status, disorientation, seizures, or decreasing level of consciousness. Any child with hemophilia who experiences a significant head injury should be evaluated immediately, even if there are no obvious external signs of bleeding. As nurses, our priority is to recognize bleeding early, monitor for signs of shock or neurological changes, administer clotting factor replacement as prescribed, and ensure prompt treatment to prevent serious complications. Idiopathic or immune thrombocytopenic purpura ITP is the most common acquired platelet disorder in children. Unlike hemophilia, which is a clotting factor deficiency, ITP is a platelet disorder, meaning the child has too few platelets to form an effective blood clot. ITP often develops 1 to 3 weeks after a viral illness. The exact cause is unknown, but it is believed to be an autoimmune response. The immune system mistakenly produces antibodies that attach to the child's platelets. The spleen recognizes these antibody-coated platelets as foreign and destroys them, resulting in thrombocytopenia, or a low platelet count. Although ITP can occur at any age, it is most common in children 2 to 4 years old. Fortunately, most cases in children are acute and self-limiting, with many recovering completely within several weeks to months. As nurses, it's important to remember that children with ITP usually have normal red blood cell and white blood cell counts. The primary problem is the low platelet count, which places them at increased risk for bleeding. Our focus is on recognizing bleeding symptoms, preventing injury, monitoring platelet levels, and educating families about bleeding precautions until the platelet count recovers. The good news is that most children with ITP recover without specific treatment. Because the condition is often self-limiting, management usually focuses on preventing bleeding while the platelet count recovers. One nursing priority is performing frequent neurologic assessments. Although rare, intracranial hemorrhage is the most serious complication of ITP. Any child who develops a severe headache, vomiting, altered mental status, or other neurological changes requires immediate evaluation. If treatment is needed because of significant bleeding or a very low platelet count, medications may include corticosteroids such as prednisone, intravenous immune globulin Vorg, or anti-D immune globulin. In children with chronic or recurrent ITP that does not respond to medical therapy, a splenectomy may occasionally be considered. Children with ITP should avoid medications that interfere with platelet function, especially aspirin and other nonsteroidal anti-inflammatory drugs and NSAIDs, because they increase the risk of bleeding. Activity may also need to be limited during the acute phase to reduce the risk of falls, bruising, and injury. Finally, remember that platelet transfusions are not routinely given in ITP because the immune system rapidly destroys the transfused platelets just as it destroys the child's own. They are generally reserved only for life-threatening bleeding or emergency surgery. As nurses, our priorities are to prevent bleeding, monitor for signs of hemorrhage, educate families about safety precautions, and recognize when bleeding becomes a medical emergency. Leukemia is the most common childhood cancer. It is a cancer of the bone marrow and blood-forming tissues, where abnormal, immature white blood cells, called blasts, multiply uncontrollably. These abnormal cells crowd the bone marrow and interfere with the production of healthy red blood cells, white blood cells, and platelets. Leukemia is classified according to the type of white blood cell involved. The two most common types in children are acute lymphoblastic leukemia ALL, which accounts for about 80% of childhood leukemias, and acute myeloid leukemia AML, which is less common but often requires more intensive treatment. As the bone marrow fills with leukemia cells, children develop anemia from decreased red blood cells, thrombocytopenia from decreased platelets, and neutropenia despite having a high white blood cell count. This means they are at increased risk for fatigue, bleeding, and serious infections. Diagnosis is confirmed through bone marrow aspiration and biopsy, along with specialized testing such as chromosome studies and immunologic markers. These tests help determine the exact type of leukemia and guide treatment. As nurses, remember that although leukemia is the most common childhood cancer, survival rates have improved dramatically, especially for children with ALL. Early recognition, prompt treatment, prevention of infection and bleeding, and compassionate family-centered care are essential nursing priorities. Diagnosing leukemia begins with a thorough history, physical examination, and blood work. Many children initially present with vague symptoms such as fatigue, fever, bruising, bone pain, or recurrent infections, so laboratory testing plays a key role in confirming the diagnosis. A complete blood count (CBC) and peripheral blood smear often reveal abnormal findings, including blast cells, which are immature white blood cells. The diagnosis is confirmed with a bone marrow aspiration and biopsy, which determines the type of leukemia and guides treatment. Additional testing helps determine how far the disease has spread. Radiographs of the long bones may show changes related to bone marrow involvement, which can explain the bone pain many children experience. A lumbar puncture or spinal tap is commonly performed to determine whether leukemia cells have spread to the central nervous system (CNS). This information is important because it influences the child's treatment plan. Before chemotherapy begins, kidney and liver function tests are also obtained. Since many chemotherapy medications are metabolized by the liver and excreted by the kidneys, adequate organ function is essential for safe treatment. As nurses, our role is to prepare children and families for these diagnostic procedures, provide emotional support, monitor for complications, and help explain the purpose of each test throughout the diagnostic process. The primary treatment for childhood leukemia is chemotherapy, which destroys rapidly dividing leukemia cells and allows the bone marrow to begin producing healthy blood cells again. Radiation therapy may also be used in certain situations, particularly if the leukemia has spread to the central nervous system (CNS) or other areas outside the bone marrow. Chemotherapy is delivered in several phases. The first is induction therapy, which aims to achieve remission by eliminating as many leukemia cells as possible. Once remission is achieved, children receive consolidation and maintenance therapy to destroy any remaining leukemia cells and reduce the risk of relapse. Children at higher risk for CNS involvement also receive CNS prophylaxis, often through intrathecal chemotherapy administered during a lumbar puncture. If the leukemia returns, reinduction therapy may be necessary. Some children with high-risk or relapsed leukemia may also require a bone marrow or hematopoietic stem cell transplant to replace the diseased bone marrow with healthy stem cells. As nurses, our role extends far beyond administering chemotherapy. We monitor for infection, bleeding, anemia, nausea and vomiting, mucositis, and chemotherapy side effects, while also providing pain management, nutritional support, emotional support, and family education. Because treatment often continues for 2 to 3 years, developing a trusting relationship with the child and family is an essential part of pediatric oncology nursing. Nursing care for a child with leukemia focuses on preventing complications, managing treatment side effects, and providing emotional support to both the child and family. One of our most important roles is encouraging the child to express their feelings and concerns. A diagnosis of leukemia can be frightening, and children may feel isolated or anxious. Creating a safe environment where they can ask questions and share their emotions helps reduce fear and correct misconceptions. Because chemotherapy suppresses the immune system, children are at high risk for infection. Nurses should perform frequent assessments for fever or other signs of infection, reinforce good hand hygiene, and teach families when to seek immediate medical care. We also closely monitor vital signs and laboratory values for evidence of anemia, infection, or thrombocytopenia. Low platelet counts increase the risk of bleeding, so assess for petechiae, bruising, bleeding gums, or prolonged bleeding after procedures. Finally, meticulous mouth and skincare are essential. Chemotherapy can cause mucositis and make the skin more fragile, increasing the risk of pain, infection, and bleeding. Gentle oral care, good skin hygiene, and early intervention for any areas of breakdown help maintain comfort and reduce complications. Throughout treatment, nurses also serve as educators, advocates, and a source of emotional support, helping children and their families cope with the challenges of living with leukemia. Hodgkin lymphoma is a cancer of the lymphatic system that primarily affects the lymph nodes. It usually begins in one group of lymph nodes and can spread in an orderly pattern to nearby lymph nodes and, if untreated, to the spleen, liver, bone marrow, lungs, and other organs. The hallmark of Hodgkin lymphoma is the presence of Reed-Sternberg cells, which are large, abnormal, multinucleated cells seen on a lymph node biopsy. Finding these cells is what confirms the diagnosis. Unlike leukemia, Hodgkin lymphoma is rare in young children and is most commonly diagnosed during adolescence and early adulthood. It is also seen more often in boys than girls during childhood. Children often present with painless, enlarged lymph nodes, usually in the neck, along with symptoms such as fever, night sweats, weight loss, or fatigue. These are sometimes referred to as B symptoms and can help determine the stage of the disease. As nurses, our role is to recognize persistent lymph node enlargement that does not resolve with infection, support children and families through diagnostic testing and treatment, monitor for treatment side effects, and provide ongoing physical and emotional support throughout their care. Nursing care for children with Hodgkin lymphoma focuses on managing the side effects of treatment, preventing complications, and providing education and emotional support to both the child and family. Many children receive chemotherapy, radiation therapy, or both. As nurses, we monitor for common side effects such as fatigue, nausea, decreased appetite, and bone marrow suppression, while encouraging adequate nutrition, hydration, and rest. Children receiving radiation therapy often experience malaise, meaning they tire easily and may become irritable or lose their appetite. Encourage activities as tolerated, while allowing plenty of opportunities for rest. The skin in the radiation treatment area may become red, dry, and sensitive. Families should be taught to protect the area from sunlight, heat, and irritation, avoid applying lotions or creams unless approved by the healthcare provider, and use gentle skincare. An important teaching point is that external radiation therapy does not make the child radioactive. It is completely safe for family members to hug, hold, and care for the child during and after treatment. Throughout treatment, nurses also provide ongoing education, monitor for infection and bleeding related to therapy, and support children and families as they cope with the physical and emotional challenges of cancer treatment. Providing emotional support is just as important as managing the child's physical symptoms. The type of support should always be developmentally appropriate, taking into account the child's age, maturity, and understanding of the illness. Encourage children and adolescents to participate in activities as tolerated. They should listen to their bodies and balance activity with rest. Maintaining as much normalcy as possible helps support emotional well-being and quality of life. For adolescents, treatment can affect puberty and body image. Chemotherapy and radiation may delay the development of secondary sexual characteristics or menstruation, which can be distressing during this stage of development. These concerns should be acknowledged openly and discussed honestly. Another sensitive topic is future fertility. Some cancer treatments can affect reproductive function, so age-appropriate education and counseling should be provided. Older adolescents and their families may also discuss fertility preservation with the healthcare team before treatment begins, when appropriate. As nurses, we provide reassurance, encourage open communication, connect families with counseling and support groups, and help children maintain hope while coping with the emotional challenges of cancer treatment. Now we're shifting our focus from disorders of the blood and lymphatic system to metabolic disorders. Metabolism refers to all of the chemical processes the body uses to convert food into energy, support growth, repair tissues, and maintain normal body functions. Many pediatric metabolic disorders are inherited, meaning a child is born with an enzyme deficiency or another abnormality that prevents the body from properly breaking down or using certain nutrients. As a result, harmful substances can accumulate in the body, or essential nutrients may not be available where they are needed. Although each metabolic disorder is unique, they share several important nursing priorities: early recognition, prompt treatment, careful dietary management, and ongoing family education. Many of these conditions are detected through newborn screening, allowing treatment to begin before permanent complications develop. As practical nurses, it is important to recognize the signs of metabolic disorders, monitor for complications, support prescribed nutritional therapies, and educate families about the importance of lifelong management. Early intervention can dramatically improve outcomes and help children achieve normal growth and development. As we discuss these disorders, think about two questions. What substance is the body unable to process, and what happens when that substance builds up? Understanding those concepts will make each disorder much easier to understand and remember. Before we discuss specific endocrine disorders, let's review the endocrine system and its role in maintaining homeostasis. The body has two major control systems, the nervous system and the endocrine system. These systems work together continuously to regulate body functions. The nervous system responds quickly using electrical impulses, while the endocrine system responds more slowly by releasing hormones into the bloodstream. Although hormones act more slowly, their effects often last much longer. Because these systems are closely connected, a problem in one can affect the other. The endocrine glands are ductless glands, meaning they release hormones directly into the bloodstream rather than through ducts. These hormones regulate many essential body functions, including metabolism, growth, development, reproduction, fluid and electrolyte balance, and the body's response to stress. In children, the endocrine system is especially important because hormones guide normal growth and maturation. That's why measuring height, weight, and growth patterns is such an important part of every pediatric assessment. Abnormal growth may be one of the earliest signs of an endocrine disorder. As nurses, understanding normal endocrine function helps us recognize when hormone imbalances are affecting a child's growth, development, or metabolism so that treatment can begin as early as possible. Several diagnostic tests help evaluate endocrine and metabolic disorders in children. The specific tests ordered depend on the suspected condition, but they help assess hormone levels, gland function, and structural abnormalities. Blood tests are among the most commonly used. They measure hormone levels, blood glucose, electrolytes, and other substances that help identify endocrine disorders. Newborn screening is especially important because it detects conditions such as phenylketonuria, PKU, and congenital hypothyroidism before symptoms develop, allowing treatment to begin early and preventing serious complications. Chromosomal studies may also be performed when a genetic disorder is suspected. Thyroid function tests, including thyroid-stimulating hormone TSH and thyroxine T4 levels, are used to evaluate thyroid disorders such as hypothyroidism and hyperthyroidism. Imaging studies also play an important role. Radiographs can assess bone age and growth abnormalities, while ultrasound provides a no-invasive way to evaluate glands such as the thyroid without exposing the child to radiation. In some situations, a tissue biopsy may be needed to diagnose abnormalities of endocrine glands. A 24-hour urine collection may also be ordered to measure hormone or electrolyte excretion, particularly when evaluating adrenal or other endocrine disorders. As nurses, our role is to prepare children and families for these diagnostic tests, explain their purpose in age-appropriate language, collect specimens accurately, and recognize abnormal findings that require prompt follow-up. Hypothyroidism occurs when the thyroid gland does not produce enough thyroid hormone. Because thyroid hormone regulates metabolism, growth, and brain development, a deficiency can affect nearly every body system. Hypothyroidism may be congenital, meaning the child is born with an absent or poorly functioning thyroid gland, or it may be acquired later in childhood. Congenital hypothyroidism is especially important because infants often appear normal at birth. Symptoms may not become obvious for several weeks or months, but untreated hypothyroidism can lead to permanent intellectual disability and growth delays. This is why newborn screening is performed shortly after birth. Early diagnosis allows treatment to begin before irreversible complications occur. When detected early, children typically experience normal growth and development. The thyroid gland controls the body's metabolic rate, so children with hypothyroidism often have slowed body functions, including decreased energy, slowed growth, constipation, cold intolerance, and delayed development. As nurses, our role is to recognize the signs of hypothyroidism, reinforce the importance of newborn screening and follow-up testing, administer thyroid hormone replacement as prescribed, and educate families that treatment is lifelong but highly effective when taken consistently. The treatment for hypothyroidism is straightforward but lifelong. Children receive a synthetic thyroid hormone, most commonly levothyroxine, to replace the hormone their thyroid gland cannot produce. Because hormone requirements change as children grow, thyroid hormone levels are monitored regularly, and the medication dose is adjusted based on laboratory results and the child's growth and development. One of the greatest benefits of early treatment is that it can prevent permanent neurologic damage in infants. However, this is why newborn screening is so important. Treatment can prevent future developmental delays, but it cannot reverse brain injury that has already occurred before therapy was started. As the child's metabolism begins to normalize, families may notice temporary effects such as mild hair loss, difficulty sleeping, irritability, or increased activity levels. These effects are usually temporary and improve as the correct medication dose is established. As nurses, we teach families that thyroid hormone replacement is taken every day for life, emphasize the importance of not missing doses, and reinforce the need for regular follow-up appointments and laboratory testing to ensure the child continues to grow and develop normally. Despite its name, diabetes insipidus (DI) is not related to diabetes mellitus. The two conditions share excessive urination, but they have completely different causes. Diabetes insipidus is caused by a problem with antidiuretic hormone ADH, also called vasopressin. DI may be inherited or acquired, such as after a head injury, brain surgery, infection, or tumor that affects the posterior pituitary gland. When the posterior pituitary does not produce enough ADH, the kidneys are unable to conserve water. Without adequate ADH, the kidneys cannot concentrate urine. As a result, the child produces large amounts of very dilute urine, even when the body is dehydrated. This leads to polyuria, excessive thirst polydipsia, dehydration, and an increased risk of hypernatremia if fluid losses are not replaced. One key point to remember is that the urine remains dilute despite dehydration, which is abnormal. Normally, the kidneys would conserve water and produce concentrated urine, but children with DI are unable to do this. As nurses, our priorities are to monitor intake and output, assess hydration status, monitor electrolyte levels, ensure adequate fluid replacement, and administer ADH replacement therapy, such as desmopressin DDAVP, when prescribed. Early recognition and treatment are essential to prevent severe dehydration and electrolyte imbalances. Diabetes mellitus is a chronic metabolic disorder in which the body cannot properly use glucose, its primary source of energy. This occurs because there is either too little insulin or the body cells do not respond normally to insulin. Without insulin working effectively, glucose cannot move from the bloodstream into the cells, causing hyperglycemia or high blood glucose. When cells cannot use glucose for energy, the body begins breaking down fat and protein instead. Fat breakdown produces ketones, which can lead to diabetic ketoacidosis (DKA) if left untreated. At the same time, protein breakdown contributes to weight loss and poor growth. As blood glucose continues to rise, the kidneys can no longer reabsorb all of the glucose. Glucose spills into the urine, drawing water with it through osmotic diuresis. This causes the classic symptoms of polyuria, polydipsia, dehydration, and increased thirst. As nurses, it's important to understand that diabetes affects carbohydrate, fat, and protein metabolism. Throughout this chapter, we'll focus on recognizing abnormal blood glucose levels, preventing complications such as hypoglycemia and DKA, administering insulin safely, and teaching children and families how to successfully manage diabetes every day. Diabetes mellitus is diagnosed using blood glucose testing. One of the most common diagnostic criteria is a fasting blood glucose level of 126 millibulars DLL or higher after at least 8 hours without caloric intake. Other tests, such as a hemoglobin A1C, oral glucose tolerance test, or a random blood glucose with classic symptoms, may also be used to confirm the diagnosis. There are two major types of diabetes. Type 1 diabetes is an autoimmune disease in which the body's immune system destroys the insulin-producing beta cells of the pancreas. Children usually have a genetic predisposition, but environmental factors are believed to trigger the autoimmune response. Because the pancreas produces little or no insulin, lifelong insulin therapy is required. Type 2 diabetes develops differently. In this condition, the body still produces insulin, but the cells become resistant to its effects. Type 2 diabetes is increasingly seen in children and adolescents and is strongly associated with obesity, physical inactivity, and a family history of diabetes. As nurses, it is important to distinguish between these two types because treatment differs significantly. Children with type 1 diabetes require insulin from the time of diagnosis, whereas treatment for type 2 diabetes may include lifestyle modifications, oral medications, insulin, or a combination of these approaches depending on the severity of the disease. Children with type 1 diabetes often develop symptoms sometimes over just a few days or weeks. The classic presentation is known as the 3 Ps: polydipsia, excessive thirst; polyuria, frequent urination; polyphagia, increased hunger. These symptoms occur because glucose remains in the bloodstream instead of entering the cells. The kidneys remove the excess glucose through the urine, which pulls water with it, causing polyuria and dehydration. The resulting dehydration leads to polydipsia. Meanwhile, although blood glucose is high, the cells are essentially starving, leading to polyphagia. Despite eating more, children often experience weight loss, fatigue, weakness, and lethargy because the body begins breaking down fat and muscle for energy. The skin may become dry due to dehydration. Adolescent girls may also experience recurrent vaginal yeast infections because elevated blood glucose promotes fungal growth. Some children may present with bedwetting after previously being toilet trained, which can be an early clue that diabetes is developing. As nurses, it's important to recognize these symptoms early. Because type 1 diabetes progresses quickly, many children are not diagnosed until they present with diabetic ketoacidosis (DKA), making prompt recognition and intervention essential. Diabetic ketoacidosis, or DKA, is a life-threatening emergency that occurs when there is too little insulin in the body. Without insulin, glucose cannot enter the cells for energy, so the body begins breaking down fat. This produces ketones, which are acidic and lead to metabolic acidosis. Children with DKA develop hyperglycemia, ketonuria, dehydration, and metabolic acidosis. Laboratory findings typically show low serum bicarbonate and a low blood pH, reflecting the body's acidic state. As ketones accumulate, children often develop a fruity or acetone odor on the breath, along with nausea, vomiting, abdominal pain, and increasing dehydration. They may also have Kussmaul respirations, deep, rapid breathing, as the body attempts to remove carbon dioxide and compensate for the acidosis. As DKA worsens, the child's mental status may change, resulting in an altered level of consciousness, ALOC, ranging from confusion to coma. Symptoms can progress rapidly within hours to days, making early recognition essential. As nurses, remember that DKA is treated with careful fluid replacement, intravenous insulin, electrolyte monitoring and replacement, especially potassium, and frequent assessment of neurologic status. One of the most serious complications during treatment is cerebral edema, so ongoing neurological assessments are a critical nursing responsibility. Education is one of the most important parts of managing type 1 diabetes. Teaching should be tailored to the child's developmental level and reinforced regularly with both the child and family. Families should understand the importance of daily foot care, including inspecting the feet, keeping them clean and dry, wearing properly fitting shoes, and reporting any cuts, blisters, or sores promptly. They should also know that infections, emotional stress, illness, and surgery can all increase blood glucose levels. During these times, children often need more frequent blood glucose monitoring, should never stop taking insulin, and may need dose adjustments according to their healthcare provider's instructions. Teach families how and when to check urine or blood ketones, particularly during illness, or when blood glucose remains above 240-250 mmol/dL, to detect diabetic ketoacidosis early. Parents and older children should recognize the signs of glucose-insulin imbalance. Hypoglycemia requires immediate treatment with 15 grams of fast-acting carbohydrate, while persistent hyperglycemia, especially with ketones, requires prompt medical evaluation. When traveling, insulin, glucose monitoring supplies, snacks, glucagon, and medical identification should always be carried. Finally, emphasize the importance of regular follow-up visits to monitor growth, adjust insulin doses, evaluate hemoglobin A1C, and screen for long-term complications. The goal of education is to help children and families safely manage diabetes while allowing the child to participate in normal activities and achieve healthy growth and development. Insulin is required for children with type 1 diabetes because their pancreas produces little or no insulin. Families must understand proper administration and safe handling. Insulin cannot be taken orally because digestive enzymes destroy the protein. It is usually administered by subcutaneous injection using an insulin syringe, pen, or insulin pump. Teaching should include correct insulin preparation, storage, and expiration checks, accurate dose measurement, and timing with meals. Rotation of injection sites, abdomen, thighs, upper arms, buttocks to prevent lipodystrophy recognition and treatment of hypoglycemia and hyperglycemia, safe disposal of needles and sharps. Many children use an insulin pump continuous subcutaneous insulin infusion, often integrated with a continuous glucose monitor CGM as a closed-loop or hybrid closed-loop system. These systems automatically adjust insulin delivery based on glucose readings, but still require regular monitoring, carbohydrate counting, and caregiver oversight. Insulin preparations differ mainly by their onset, peak, and duration of action, which determine when they begin working, when they are most effective, and how long they lower blood glucose. Insulin response is individualized and can be influenced by factors such as the injection site, blood flow, physical activity, dose, illness, and insulin absorption. Children may receive insulin by subcutaneous injection syringe or insulin pen. Insulin pump continuous subcutaneous insulin infusion, which provides continuous basal insulin with programmable mealtime boluses and may integrate with a continuous glucose monitor, CGM. The Somogy phenomenon is rebound hyperglycemia that occurs after an episode of unrecognized hypoglycemia, most often during the night. When blood glucose falls too low, the body releases counter-regulatory hormones, glucagon, epinephrine, cortisol, and growth hormone. These hormones stimulate the liver to release stored glucose, causing blood glucose to rise excessively by morning. Key points caused by too much insulin, especially at bedtime. Results in morning hyperglycemia following nocturnal hypoglycemia, confirmed by checking blood glucose around 2-3 a.m. For hypoglycemia, management may include reducing the evening insulin dose or adding a bedtime snack, as directed by the healthcare provider. Clinical Pearl. Differentiate the Somogy phenomenon from the dawn phenomenon. The Somogy phenomenon follows overnight hypoglycemia, whereas the dawn phenomenon is caused by early morning hormone release without preceding hypoglycemia. Type 2 diabetes is characterized by insulin resistance and progressive beta cell dysfunction, resulting in hyperglycemia. Although once rare in children, it is becoming more common, especially in adolescents. Major risk factors include obesity, especially central obesity, physical inactivity, family history of type 2 diabetes, poor dietary habits, certain ethnic backgrounds and conditions such as polycystic ovary syndrome. PCOS management focuses on healthy nutrition and weight management. Regular physical activity, blood glucose monitoring, oral medications. Metformin is first line for many children. Insulin therapy, if lifestyle changes and oral medications do not adequately control blood glucose, or at diagnosis when hyperglycemia is severe. Clinical Pearl. Unlike type 1 diabetes, children with type 2 diabetes usually continue to produce insulin, but their bodies do not use it effectively. Lifestyle modification remains the foundation of treatment. This section introduces how the immune system protects children from infection, the transmission and prevention of communicable diseases, and the nursing care needed to reduce complications and promote recovery. Key concepts include the body's innate and adaptive immune defenses, modes of disease transmission, and infection prevention standard and transmission-based precautions, childhood immunizations and vaccine-preventable diseases recognition, and management of common pediatric infectious diseases. Nursing care, family education, and strategies to reduce the spread of infection. Clinical Pearl. Children are more susceptible to infection because their immune systems are still developing. Immunization, good hygiene, and early recognition of illness are essential to preventing serious complications. Immunity is the body's ability to recognize and defend against pathogens. It is classified as innate, natural, or acquired adaptive and can be either active or passive. Natural innate immunity. Present at birth and provides immediate, non-specific protection. Examples: skin, mucous membranes, stomach acid, tears, inflammation, phagocytes. Acquired adaptive immunity develops after exposure to a pathogen or through immunization and provides specific protection. Examples: developing immunity after recovering from chickenpox or after receiving the measles MMR vaccine. Types of acquired immunity include active immunity. The body produces its own antibodies after infection or vaccination. Protection is usually long-lasting. Examples: recovering from chickenpox, receiving the MMR vaccine, hepatitis B vaccine, or influenza vaccine. Passive immunity ready-made antibodies are received from another source. Protection is immediate but temporary. Examples: maternal antibodies transferred through the placenta IgG, antibodies in breast milk IgA, rabies immune globulin RIG, hepatitis B immune globulin HBIG, tetanus immune globulin TIG, or intravenous immune globulin IVIG. Clinical Pearl. Remember natural active infection body makes antibodies, for example. Chickenpox. Artificial active vaccination body makes antibodies, for example, MMR vaccine. Natural passive. Mother provides antibodies placenta or breast milk. Artificial passive immune globulin provides antibodies, for example, RIG, HBIG, IVIG. Preventing infection is a primary nursing responsibility and is achieved through aseptic technique, standard precautions, and transmission-based precautions. Aseptic technique, practices that reduce or eliminate microorganisms during patient care. Used with all patients when performing procedures such as dressing changes, injections, catheter care, and wound care. Standard precautions applied to every patient regardless of diagnosis include hand hygiene before and after patient contact, appropriate protective equipment PPE based on anticipated exposure, gloves, gown, mask, eye protection, safe handling of sharps and contaminated equipment, respiratory hygiene, cuff etiquette. Transmission-based precautions. Additional precautions used for patients with known or suspected contagious infections based on the route of transmission, contact. Gloves and gown, for example, MRSA, RSV, C. difficile droplet surgical mask, for example, influenza, pertussis, meningococcal meningitis, airborne. N95, respirator and negative pressure room, for example, tuberculosis, measles, varicella. Clinical Pearl. Hand hygiene is the single most effective measure to prevent healthcare-associated infections. Use alcohol-based hand sanitizer unless hands are visibly soiled or caring for patients with C. difficile, when soap and water are required. Protective environment protective isolation is used to protect immunocompromised patients from exposure to infectious organisms. It is not used because the patient is contagious, but because the patient is highly susceptible to infection. Patients who may require a protective environment include severe neutropenia, very low neutrophil count, hematopoietic stem cell transplant HSCT recipients, other patients receiving intensive chemotherapy or immunosuppressive therapy nursing care, includes strict hand hygiene for all staff and visitors, appropriate PPE according to facility policy private room. Some patients require positive pressure airflow with HEPA filtration. Restrict visitors with signs of illness, avoid fresh flowers, live plants, and standing water, which can harbor microorganisms. Use meticulous aseptic technique for all invasive procedures. Clinical Pearl, protective isolation protects the patient from the environment, whereas transmission-based precautions protect others from the patient. Some patients may require both protective isolation and transmission-based precautions, depending on their condition and infection status. This slide is emphasizing infection prevention in immunocompromised children, for example, children receiving chemotherapy, transplant recipients, or those with severe neutropenia. Here's how I would teach each point to LPN students: family education to prevent the spread of infection, hand hygiene. Wash hands with soap and water or use alcohol-based hand sanitizer before eating, after using the restroom, after coughing, sneezing, after touching pets, and before providing care. This is the single most effective way to prevent infection. Keep immunizations up to date, ensure the child and household members receive recommended vaccines. Discuss any live vaccines with the healthcare provider if the child is immunocompromised. Practice safe food storage, refrigerate perishable foods promptly. Keep raw meats separate from ready-to-eat foods. Discard expired or spoiled foods. Use only pasteurized milk and dairy products. Avoid raw, unpasteurized milk and cheeses made from unpasteurized milk because they may contain harmful bacteria. Cook meat thoroughly. Thaw meat safely in the refrigerator, microwave, or cold water, never on the countertop. Cook meat, poultry, seafood, and eggs to recommended safe internal temperatures. Do not share towels or personal items. Avoid sharing towels, washcloths, razors, toothbrushes, drinking cups, or eating utensils to reduce the spread of microorganisms. Control insects. Reduce exposure to mosquitoes, ticks, fleas, and flies by using screens, insect repellents as appropriate, and eliminating standing water. Avoid sandboxes. Sandboxes may be contaminated with animal feces containing organisms such as Toxoplasma gondii or other parasites and bacteria, increasing the risk of infection in immunocompromised children. Clinical Pearl for students teach families that infection prevention begins at home. Good hand hygiene, safe food handling, avoiding exposure to sick individuals, and keeping the environment clean can significantly reduce infection risk in children with weakened immune systems. Multiple doses may be needed. Some vaccines require a series of doses plus booster doses to produce long-lasting immunity. Receiving all recommended doses is necessary for maximum protection. Examples: hepatitis B, diphtheria-tetanus, a cellular pertussis DTaP, human papillomavirus HPV vaccines prevent disease. They do not treat existing disease. Vaccines stimulate the immune system to produce antibodies before exposure to a disease. They are preventive, not curative. Example: the measles, mumps, and rubella MMR vaccine prevents measles but will not treat someone who already has measles. Route of administration matters. Different vaccines are designed to be given by specific routes to ensure they produce the best immune response. Intramuscular IM, hepatitis B, DTaP, influenza inactivated, subcutaneous subQ MMR, varicella oral rotavirus intranasal live attenuated influenza vaccine LAIV. Administering a vaccine by the wrong route may reduce its effectiveness or require revaccination. Proper storage and handling cold chain. Maintaining the correct temperature preserves vaccine potency. Store most refrigerated vaccines at 2 degrees Celsius to 8 degrees Celsius, 36 degrees Fahrenheit to 46 degrees Fahrenheit. Do not store vaccines in the refrigerator or freezer door because temperatures fluctuate. Store vaccines in the center of the shelves, away from cooling vents. Monitor and document refrigerator temperatures according to facility policy. Never refreeze vaccines that should not be frozen after thawing. Discard vaccines that have been improperly stored according to CDC manufacturer guidelines. Key nursing teaching points: keep an accurate immunization record. Mild fever, soreness, or redness at the injection site are common after vaccination. Report severe allergic reactions, immediately difficulty breathing, facial swelling, generalized hives. Follow the CDC recommended childhood immunization schedule. Clinical Pearl, the 5 rights of vaccine administration. Right patient, right vaccine, right dose, right route. Right time, correct age and interval. These principles help ensure vaccines are both safe and effective. Although serious vaccine reactions are rare, nurses must always be prepared to respond. Epinephrine should be immediately available anywhere immunizations are administered in case of anaphylaxis, a life-threatening allergic reaction. After vaccination, children should be observed for at least 15 to 20 minutes for signs of an allergic reaction, such as hives, swelling, wheezing, or difficulty breathing. Before administering any vaccine, carefully review the child's allergy history. Certain vaccine components may be contraindicated in patients with severe allergies. A severe yeast allergy is a contraindication to recombinant hepatitis B vaccine. A severe neomycin allergy is a contraindication to vaccines containing neomycin, including MMR, varicella, and inactivated polio vaccine IPV. One important update to this slide involves egg allergy. Current CDC recommendations state that children with egg allergy can safely receive influenza vaccines regardless of the severity of the allergy. MMR is also safe in children with egg allergy because it does not contain enough egg protein to cause an allergic reaction. As an LPN, always screen for allergies before vaccination, have emergency supplies readily available, observe the child after immunization, and follow current CDC guidelines. Before administering any vaccine, screen for contraindications to ensure it is safe. Children who are immunocompromised may not be able to receive live vaccines, although inactivated vaccines are often still appropriate. Pregnancy is also a contraindication for certain live vaccines, such as MMR and varicella. Vaccination is usually postponed during moderate or severe acute illness, such as bacteremia or meningitis, until the child recovers. Children receiving high-dose corticosteroid therapy may need to delay live vaccines because of immune suppression. An immunocompromised caregiver in the home may require individual evaluation before certain live vaccines are given. Finally, always ask about previous vaccine reactions. A history of anaphylaxis to a vaccine or one of its components is a true contraindication. Remember, minor illnesses such as a mild cold or low-grade fever are not reasons to delay routine immunizations. As an LPN, always review the child's health history, medications, allergies, and previous vaccine reactions before administering vaccines. Children have unique characteristics that make them more vulnerable during disasters and hazardous exposures. They have a larger body surface area and thinner skin, allowing chemicals and heat to be absorbed more easily. They also have higher respiratory rates and smaller airways, making them more susceptible to inhaled toxins and respiratory distress. Because children are closer to the ground, they may be exposed to higher concentrations of heavier than air gases and chemicals. Their immature blood-brain barrier also makes them more sensitive to certain toxins, including nerve agents. During emergencies, medication dosing should be based on the child's size. The Brasilo tape provides rapid, color-coded weight estimates to reduce medication errors, and pediatric antidote dosing guides may also be used during chemical exposure events. As an LPN, remember that children are not simply small adults. Their anatomy and physiology require special assessment, treatment, and medication dosing during disaster situations. Sexually transmitted infections, or STIs, are infections that are primarily spread through sexual contact. They can also be transmitted from a pregnant mother to her baby during pregnancy, labor, or delivery, and some infections can spread through contaminated needles or blood exposure. In pediatric patients, the presence of an STI may raise concern for sexual abuse, particularly when the infection cannot be explained by perinatal transmission. As healthcare providers, nurses are mandatory reporters and must follow state laws for reporting suspected abuse. Many STIs are reportable diseases, meaning they must be reported to the local public health department. Public health officials help with contact tracing, notifying sexual partners or close contacts so they can be tested and treated if necessary. As an LPN, provide care without judgment, maintain patient confidentiality, educate patients about prevention, and encourage prompt testing and treatment to reduce transmission and complications. When caring for a patient with an STI, the nurse's role extends beyond physical care to providing emotional support and education. Create a safe, private, and non-judgmental environment so the patient feels comfortable discussing sensitive concerns. Listen respectfully, encourage questions, especially during examinations and discussions. Explain when confidentiality may be limited, such as mandatory reporting requirements for minors or certain reportable diseases. Assess the patient's current knowledge, correct misconceptions, and provide education about treatment, preventing transmission, partner notification, and follow-up care. Finally, help the patient maintain a positive self-image. Many patients experience fear, embarrassment, or stigma after an STI diagnosis. Providing compassionate, respectful care can reduce anxiety and improve treatment adherence. Children with HIV have weakened immune systems, making them more susceptible to recurrent and opportunistic infections. Common manifestations include failure to thrive, persistent enlarged lymph nodes, chronic sinus infections, and infections that are difficult to treat. Opportunistic infections such as oral thrush, pneumocystis jirovecii pneumonia, PJP, herpes infections, and cytomegalovirus CMV are common as the immune system becomes more compromised. Treatment focuses on antiretroviral therapy, ART, which suppresses the virus, slows disease progression, and improves quality of life. While there is no cure for HIV, ART has greatly increased life expectancy for children with HIV. Supportive care is also essential and includes preventing and treating infections, maintaining good nutrition, promoting growth and development, and providing psychosocial support to the child and family. Children should also remain up to date on recommended immunizations, with vaccine selection based on their immune status and current guidelines. As an LPN, monitor for signs of infection, reinforce medication adherence, educate families about preventing transmission, and provide compassionate, non-judgmental care.